the candidate does the presentation. Then there's public questions, so anyone in the room. We then excuse the public and leaving the committee behind, which is Aaron, Steve, myself, and Dina Demner-Pushman from Bethesda, Maryland. And then the exam committee excuses the candidate, and we make a decision as to whether the thesis is successfully defended. So our candidate today, who most people in the room know, is Dr. Tracy Edinger, who's also a postdoc fellow funded by the National Library of Medicine, and she's been with us for a while. Tracy's background is that she's a naturopathic physician, and she has been pursuing informatics in her fellowship. So I will let her go from here.
Great, thank you.
And let us know, Dean, if you can't hear anything or...
No, I'm hearing you just fine.
Okay, good.
And I just got the slides, so I'm all set.
Okay, and then I guess we're actually streaming this, so so if people out there in cyberspace want to ask a question, tweet at OHSU Informatics, all one word, and also hashtag, we'll see it anyways, but if you do hashtag DMICEConf, DMICECONF, we'll catch it as well, and I'll monitor the Twitter feed here. So, go ahead.
Great. Well, thank you. Thank you all for coming. My topic is evaluation of clinical text segmentation to facilitate cohort retrieval. So what I was trying to do was find a way to make it easier to find different groups of patients in medical text. I started the project last summer at the National Library of Medicine and then continued it when I got back here to OHSU. So to give a little bit of background, we all know that electronic health records, or EHRs, are increasingly being used by independent practitioners and in hospitals and other clinics. A big incentive to do this has been the funding from the U.S. government, who's put a lot of money into helping people implement EHRs in an effort to improve healthcare. EHRs can improve healthcare by making data available to providers in a direct patient contact, but also by having that data available later on for different secondary uses. We can use the information for quality improvement, disease surveillance, business applications, research for a number of different topics. For all of those secondary uses of data, it's important that we be able to retrieve a specific group or cohort of patients that we're looking for. In order to talk about how we're going to retrieve patient cohorts, we need to take into mind how the data is stored in the EHR. Some of the data is stored in a structured format where you have a fixed finite list of codes or text elements that you can use to enter into the data. A lot of it is stored as text, free text. There's also images, waveforms, a multitude of different ways to store the data. The way that the data is stored is going to determine how you can retrieve it. A number of studies have looked at retrieval of patient cohorts using structured data. Trying to retrieve cohorts with structured data is going to give you the most accurate results in terms of retrieving exactly what you're asking for and the full cohort of what you're asking for. But it might not retrieve all of the patients that you're really trying to capture. One study looked at this problem, looking at electronic health records over a 10-year period at one institution. They looked at retrieving patients who had had colonoscopies using the procedure codes and looking at the text, and found that using the procedure codes only let them retrieve about 60% of the relevant patients. So it's important that we be able to use the text to help retrieve the full cohort that we're looking for. And there have been a few large-scale studies that have tried to improve the ability to do this. One group that's working on this is Informatics for Integrating Biology in the Bedside, or I2B2, and they've looked at retrieving cohorts of obese patients or looking at retrieving smoking status of patients. The Electronic Medical Records and Genomics Network, or eMERGE, has also looked at retrieving patient cohorts over from different sets of electronic medical records, focusing on similar cohorts and also diabetic patients and patients with histories of cardiac disease. The National Institute of Standards and Technology Text Retrieval Conference Medical Records Track, or TREC-MED, is another large-scale work that tried to foster improvements in retrieving patient cohorts. A lot of the work that was done at OHSU for TREC-MED has formed the basis of this project. So I'm going to talk a little bit about TREC-MED and how information retrieval worked for that project. For TREC-MED, there were 88 participants across the United States. They were each given a set of different clinical topics and a set of de-identified medical records, and the goal was to retrieve all of the patients relevant to each topic from that set of records. They developed search systems and algorithms to try to retrieve those documents or patients. And then when a search system runs a search, it'll return a ranked list of documents that might be relevant to the topic, with the highest ranked one being the most likely to be relevant, and then on down to the least likely to be relevant. For TREC-MED, all of those results were pooled from all of the participants and all of the runs that they did, and then a subset of the documents was judged for relevance. And then performance of individual participants and runs was judged against those judged documents. So back to retrieving cohorts from clinical text. There are a number of features of medical text that make it difficult to search. There are a lot of differences in terminology and spelling, where you might have multiple terms that refer to the same condition or different ways to spell things. Multiple meanings for terms that might be context dependent. There are a number of acronyms used in medicine that have different meanings depending on the context. As an example, BS can stand for breath sounds in a respiratory exam, or bowel sounds in an abdominal exam. Medical text often refers to things that happen at different points in time. So you might have a documentation of past medical history of a patient, the current history, and possibly references to potential future illnesses. Medical text also has a lot of negation. It's really important to document findings or the absence of findings, and it's as important to document the presence of them. So you'll find a lot of negation. There are also references to illnesses in other people, particularly in the family history. Clinical text is structured in a way that helps provide clues for somebody reading it to resolve some of those ambiguities. A typical structure of a medical note is using the SOAP format, where the subjective section documents information that the patient reports to the clinician. The objective section documents things that can be measured or observed. The assessment documents the clinician's thinking about what's going on with the patient, and the plan indicates what will be done. And within the subjective and objective section are further subsections. In a history, the subjective section will be broken down to distinguish the chief complaint, history of the present illness, where the clinician will document everything leading up to or around that illness, past medical history, social history, and family history. And in the objective section on a physical exam, you'll typically find different sections for different body systems. So if we look a little bit closer at a chart note, this one documents that the patient had an ulcer at age 10. So if we're searching in this set of documents for patients with ulcers, we're going to retrieve this document even though it's not one that we're looking for. It also documents family history of strokes, and similarly, if you look for stroke, you're going to retrieve this even though it might not be the one you want. A number of algorithms have been published by different researchers that break the text down into these different segments. In all of the papers, the researchers documented how well their algorithm worked at breaking the segments apart, but I couldn't find any published studies that evaluated whether segmenting actually improved recall. So the hypothesis of this project was that searching the segmented clinical text would improve the accuracy of retrieving patient cohorts. So for my project, I obtained a set of clinical documents, segmented them. I developed a set of topics for different patient cohorts. I developed a set of queries for each cohort with and without sections. And then I judged a subset of the documents for relevance to see how the segmented queries performed, and then analyzed the results. The data that I used was the MIMIC2 database. This is a research database developed by MIT, Philips Medical Systems, and Beth Israel Deaconess Medical Center. It contains de-identified data for ICU patients, neonatal and adult patients. It's a relational database that contains structured and unstructured text. There are about 25,000 patients in there, and 4 types of clinic notes. There are discharge summaries, MD notes, radiology reports, and nursing notes. This is what the documents looked like before they were segmented. All of the text in the document was embedded in opening and closing XML tags labeled text. So if you search, you're searching the whole note. And then after I segmented, they looked like this, where each section was broken apart and again indicated by opening and closing XML tags. The tags were inserted automatically using a program that looked for indicator text. There was a long list of indicator text that I developed, and every time the program found that in the clinical document, it would insert the XML tags. So to come up with the indicator text, I started with a list that had been developed at the NLM for TrekMed, and then I examined the MIMIC documents to see what needed to be added to it. So I looked at a subset of each of the 4 types of documents, listed all the possible ways that the indicator text would be identified, and those were put into the list that the tool used. So for example, here the allergies section is indicated by allergies : allergies dash, allergy to, and allergic to. So when the automated tool looked, it would find any one of those variations and tag that as the allergies section. Each time it found any of that indicator text, it would put in the opening tag for that section, and then just before the opening tag, it would put in the close tag for the previous section. So it didn't actually look for the end of a section. It was implied by the presence of the beginning of a new one. The search engine that I used was a search engine developed by the National Library of Medicine, the SE search engine. It was developed to help non-clinicians search medical literature, and it does that by mapping terms through the Unified Medical Language System so that a non-clinician can put in a term and it'll be mapped to a clinical term that might not have the same words but means the same thing. The UMLS does that term mapping by concept, so each different term is mapped to a specific concept, and that lets it relate the terms that are equivalent. The SE search engine maps the text that's entered into it to concepts in the UMLS. So in the MIMIC data, it would search every word there, and every time it found something, it would tag it to one of the UMLS concepts. And it does the same thing when you put in a search query. it'll look for your terms and match them to the UMLS concepts so that they can be equated. When you run a search in SE, you receive a list of documents that it has flagged as possibly relevant to the topic. They're ranked from possibly most relevant to least relevant, and then SE also assigns a score between 0 and 1, indicating the likelihood that it's relevant to the topic. For the term matching that SE uses with the UMLS, there are 5 different levels of mapping that you can select. And for this project, I used 3 of those. No expansion tells SE to look for an exact literal match. So if you know you want to look for Hashimoto's thyroiditis and not anything else, you can indicate that you want to do that. Concept expansion will branch out to include synonyms of search terms. So here it'll match Hashimoto's thyroiditis to autoimmune thyroiditis. And relaxation expansion breaks up the sections of the search text and will look for synonyms for each fragment. So in this case, you pull in all forms of thyroiditis, not just autoimmune. For my clinical topics, I again began with topics that were developed for TrekMed. Because the data sets used for the 2 projects were different, I had to modify them for the MIMIC data. The Trek data set included emergency department reports and reports from all patients who had been admitted to the hospital, whereas the MIMIC data only included ICU patients. So there were some tweaks that had to be made to the topics to make them relevant to the current data set. The final set included 22 different clinical topics. And my queries, the queries in SE are Boolean expressions that are composed of terms and operators. The terms are the concepts that you want to find in the documents, and the operators determine how the searches are performed. The primary operators are and, or, and not. So, for example, diabetes and thrombocytosis, that query will specify that both of those topics have to be in the document in order to retrieve it. Celiac disease and not celiac artery specifies that the document has to contain celiac disease and not contain celiac artery. Bed sore and pressure ulcer is going to look for one or the other or both. The queries were developed initially without sections. Query development was an iterative process. I developed the query, ran it against the data, looked at the data that I retrieved, and then refined the queries as needed to either avoid retrieving non-relevant documents or to try to pick up more of the relevant documents. I didn't use any site-specific details because I wanted the results to be as generalizable to other data sets as possible. Once I had the baseline query written, I changed it to use the sections. I tried to use the same terms and Boolean operators as much as I could, but in some cases it wasn't possible because of how the sections changed the query. And then I, again, ran the queries against the data and revised them as necessary. And then once they were both complete, I ran them and recorded all the documents that were returned. So here's an example of a query with and without sections. The topic is patients with diabetes who also have thrombocytosis. And the baseline query looks for both of these terms in the document. The section query looks for thrombocytosis anywhere in the document, but then is very specific about where in the document it looks for diabetes in order to avoid picking up people with a family history of diabetes or maybe a mention of it in the social history. For sampling the documents, I my queries returned over 12,000 documents, so I could not read them all and judge them for relevance. So I had to sample a subset of them. So I focused on the difference in scores for the documents retrieved by the baseline and segmented queries to determine which documents I would sample. When both queries returned the same document, I looked at up to 10 with the highest difference in score in either direction, where the segmented score was higher than the base score or the segmented score was lower than the base score. And then I also sampled documents that had been returned by one query but not the other. Because of the way that the queries return documents, and a lot of the a lot of the documents had the same score, I didn't always have my ideal sample of 40 documents per topic. So my total sample size was 574 documents, but the sample sizes ranged from 10 to 40 for each of the topics, and the average was 26 documents per topic. To evaluate whether the documents were relevant to the topic and to evaluate performance, I looked through each document and then coded several different things, whether it was relevant to the topic, whether the segmentation had been done correctly, whether segmentation helped retrieval and why, and why any non-relevant documents were retrieved. So the documents that I retrieved were mostly discharge summaries, almost 400 of them. I got back 142 radiology reports, that I judged, and 37 nursing notes. There weren't any MD notes in the set that I judged, but the MD notes pertained only to neonatal patients, and none of the topics were for infants. They were all for adults, so that's what we expected. I looked at relevance of the documents to the topics, and the top row shows all relevant documents. There were 343 that were relevant. 246 of those were retrieved by both queries. 20 of those were retrieved by the segmented queries only. 77 by the base only. The next row shows the non-relevant documents. There were 231 of those. 82 were retrieved by both queries. The segmented queries retrieved only 6 non-relevant documents that weren't retrieved by the base queries, and the base queries retrieved 143 documents that weren't retrieved by the segmented queries. And then the bottom line shows all of them together. I split it out into how many relevant documents the segmented queries retrieved out of all documents retrieved by the segmented queries, and about 75% of the documents retrieved by the segmented queries were relevant, compared to 58% for the base queries. I looked at reasons that non-relevant documents were retrieved, and this is a summary of them, and I'm not going to go into a lot of detail on this right now because it was not the main focus of this project, but they followed similar research that we've done in the past, where there were a lot of irrelevant references to conditions, like in family members or other people, past or future conditions that weren't current, conditions that were mentioned but not actually diagnosed, conditions that were denied or ruled out. I did have a couple of reasons for retrieving non-relevant documents that were unique to this project. One was an issue with mapping of terms that came up with the topic patients with HIV/AIDS, where AIDS in SE mapped to acquired immune deficiency syndrome, AIDS, assist, help, and other things that were totally unrelated. And then there were several cases where the query just could have been written better, and that impacted. Looking at performance of the segmented queries, there were 132 documents that were not retrieved by the segmented query because it was able to avoid looking in certain sections of the document. And similarly, there were 20 documents where the segmented query was able to focus on specific sections and retrieve relevant documents. One of those topics was patients with taking atypical antipsychotics without a diagnosis of bipolar disease or schizophrenia, where the base query was excluding those diseases from the document, but the segmented query was able to avoid looking in the family history where a lot of those irrelevant references were found. In most of the cases, the performance of the query was not related to segmenting at all. In 80 cases, the query just didn't look in the right sections, and so the segmented queries didn't retrieve relevant documents. There were 18 documents that weren't segmented correctly, where that had an impact on retrieval, and one document where the condition was noted in a section of notes that it's not normally. It was a patient with delirium, and it was mentioned only in the social history. So a little more detail on some of these, where the segmented documents were able to avoid retrieval, or segmented queries, were able to avoid retrieval of non-relevant documents. Here are two of the topics where that helped. Patients who develop thrombocytopenia in pregnancy, the neonatal notes will often document the mother's pregnancy history. So when I was searching for these conditions, it was pulling, the base query was pulling a lot of neonatal notes, but the segmented query was able to focus on sections where the condition of the actual patient was documented, like the chief complaint or a discharge diagnosis or admission diagnosis. Patients who have gluten intolerance or celiac disease, the celiac disease was being confused with the celiac artery, so the queries specified that celiac artery not be present in the document, but that was causing confusion, and the segmented query was able to avoid those by focusing on specific sections. There were 20 documents that were retrieved by the segmented query because it was able to focus on specific sections. I think I mentioned earlier patients taking atypical antipsychotics without a diagnosis of schizophrenia or bipolar. The segmented query was able to avoid looking in the family history section, and so was able to retrieve relevant documents. In patients with low back pain who had imaging studies, lumbar was used in that query as a synonym for low back, and that was picking up patients who had had lumbar punctures. So both queries excluded lumbar puncture, but the segmented queries were able to focus that on procedure notes, and so it was picking up patients who had low back pain and had happened to have lumbar punctures. In several cases, the query just didn't look in the right section. Patients with thyrotoxicosis treated with beta blockers, some of the thyrotoxicosis was noted in the preamble and the history of the present illness, and my segmented queries didn't look there. In patients with colon cancer who had chemotherapy, in most of the cases there, the patients were admitted for different conditions, so the colon cancer was noted in the past medical history, even though it was a current condition. There were a few cases where the document wasn't segmented correctly, and that had an impact on retrieval. In all of these cases, there wasn't an explicit section heading, so the section that I was looking for had actually been put into the previous section. For example, in one topic, delirium was mentioned in the physical exam, but that didn't have an explicit heading, so it was incorrectly included in the social history where I was not looking. And the other one was looking for patients with depression, which was noted in the problem list but not split from the allergy section, and I was not looking in allergies for depression. And again, I found one case where a condition was noted in a section of the notes you wouldn't expect it. So to analyze my results, I looked at a couple of different things. I looked at a correlation to indicate whether the segmented query had an impact on performance. And I also calculated precision, recall, and fallout. I used Matthew's correlation coefficient. This is a measure that's used in machine learning to evaluate the performance of a binary system. And it is stable and valid with small sample sizes, which was good because the sample sizes I used were small. To calculate this, I looked at the difference in score between the segmented and base queries. If one of the queries didn't return a document, I used a score of 0 for that. If the segmented score was higher than the base, then it was considered a positive finding. If it was lower than the base, it was a negative finding. And then I split those into whether the document was relevant or not. Matthew's correlation coefficient ranges from -1 to 1. If you have only true positives and true negatives, the MCC is 1, indicating that there's perfect correlation between the performance of your system and the results. If it's -1, you'll get that if you only have false positives and false negatives, indicating that the system did exactly the opposite of what you wanted. And if they're mixed equally, it'll be 0, indicating that the system didn't have any impact on performance. The calculation for MCC is shown at the bottom. And here are the results across the different queries. There were 6 topics where I couldn't calculate it because of a 0 in the denominator. And the scores here range from -2 to 0.9. I calculated significance for all of them, and I think 8 of them were significant, 2 at the 0.05 level and 6 at 0.01. Overall, the average was a little bit over 0.4, and that was also significant. And that indicates that sectioning or using the section queries had a moderate improvement on recall. This is one of the topics where I couldn't calculate Matthew's correlation coefficient. Both queries returned almost the same set of 4,500 documents with identical scores. I was only looking at documents with different scores, so my sample for this topic was only 10 documents that were retrieved only by the base query. Patients with diabetes who also have thrombocytosis had the highest MCC of 0.91. In this case, the base query retrieved 10 documents that were not retrieved by the segmented query. Those were the true negatives. And this was the lowest one, patients with esophageal cancer who developed pericardial effusion. The MCC here was -0.2, and there were 7 documents that were relevant but retrieved only by the base query, causing the score to be lower. I also calculated precision, recall, and fallout. Precision, and these are a little bit different from how they're normally calculated because I was only looking at the documents that I judged, not the entire sample. So for this case, precision was the number of relevant documents retrieved divided by the number of documents judged. Recall was the number of relevant documents retrieved divided by all relevant documents judged. And fallout is the number of non-relevant documents retrieved divided by all non-relevant documents judged. This is precision for the segmented and base query. The segmented results are red and the base ones are blue. And in most cases, the base query outperformed the segmented queries. And I actually have speaker's notes that I couldn't get to, and I don't remember which one that is. I think that was the patients taking atypical antipsychotics where the segmented query had perfect precision in the base query was 0. This is recall, and again, the base queries almost across the board outperform the segmented queries, except for that atypical antipsychotic topic. And this is fallout, where in this case, the lower the number, the better the performance, because you don't want to retrieve non-relevant documents. And here the segmented queries outperform the base queries in all cases but one. So overall, segmented queries returned fewer documents, but the ones that they returned were more likely to be relevant to the topic. It would possibly help to combine the queries and maybe use the base queries to retrieve your first set of documents and then run the segmented queries against them to get an idea of which ones are more likely to be relevant or not. In this project, a lot of the queries performed better than others, and then some document types were segmented better than others. There were also differences in what was documented in the different document types that I think I will get into here. There were a lot of limitations to this work. It was a really small sample size. In information retrieval, it's typical to judge hundreds of documents per topic instead of less than 40. There was only one person doing the relevance judgments, and it would have been better to have somebody else doing the relevance judgments and not the same person who had written the queries and written the topics and done all the searches. There were a lot of inaccuracies in identifying the note segments, especially when they were not explicitly headed. And the queries themselves needed a lot of improvement. I tried as I went along to improve them, but when I re-stratified the sample by comparing the scores, a lot more room for improvement emerged. So future work in this direction, I think, would include using one of the validated algorithms to segment the text, definitely using a larger sample size, and then independent relevance judges so that it's not the same person doing all pieces of the work. And then, again, different clinical notes document different types of things or document it in different ways. The nursing notes don't tend to document the diagnoses as much, whereas the discharge summaries document diagnosis, assessment, workup, and the radiology reports don't tend to document or diagnose things as definitively, where they'll often say, this finding is consistent with this. So developing the queries to take into account those note differences would be very helpful. I also think it would be a good idea to include structured data and unstructured data together, because that would more accurately reflect what happens in the real world. So I would like to thank all of you for being here. I'd like to thank my advisor and committee, Bill Hirsch, Dina Demner-Fushman, Aaron Cohen, and Steve Bedrick, the DMICE faculty, staff, and students. I'd like to thank the NLM for my funding and for providing resources for this project, and Swapna Abhyankar, Russell Lone, and Francoise Lang for their clinical and technical expertise. Any questions?
Thank you. Any questions for Tracy? I don't see any tweets.
Oh. I have a question. Nobody else has a question. So, some of the retrieval errors you found had to do with the queries. Do you think now that you've done this, you could improve both the segmented and the non-segmented queries? And to what extent, and do you think that there's more or less opportunity to improve one of the kinds of queries versus the other now that you have a lot more experience with this?
I think they could both be improved. I think the segmented queries could be improved more than the non-segmented ones. I thought about showing an example of one of them, but some of them got to be really long. When I split the documents, I ended up with 36 different sections. And so to be really complete, there were cases where I ended up with a lot of, phrases or whatever in the query. And there were places where I didn't develop the query quite as extensively as it could have been.
So to help me understand with the queries, so did you kind of develop them yourself, or did you go off of previous research to kind of get it started and then it evolved?
I started with queries that were developed for TrackMed by OHSU and by the NLM, and kind of combined pieces of those because they were the same topics, and then altered them to fit the MIMIC data and any changes in the topics.
And those queries came from, just because she might not be familiar with TrackMed. Not everyone in the room knows what TrackMed is. But
so where did the queries come from? Did somebody write those queries in the first place? Were they an automatic query processor?
They were not automatic. They were, I don't know. I wrote some of them just by looking at the topic and the different, diabetes, and incorporating as many terms that would refer to that as possible.
So you would maybe look at the data and then say, oh, okay, maybe I need to add this in because I'm seeing a pattern. Okay, that's helpful.
Just as an FYI, the topics in TrackMed were designed to represent patients who might be candidates for clinical studies. We got those from a variety of sources, but the idea was to, in TrackMed, which we played a significant role in, was to identify, like Tracy's done, cohorts of patients who might be candidates for clinical studies from medical records.
The topic might be patients who had X, Y, and Z, but not Y, and were over age blah, kind of thing. So they weren't all that detailed, but some were fairly detailed, some were a little bit vague, but like patients with cancer. Mm-hmm. And the idea was that you were trying to simulate the task of a researcher trying to identify a cohort for a study, sitting in front of a search box in front of Epic and needing to find matching records.
That makes perfect sense. Kind of puts a little context behind why you might be venturing down that path.
And you brought up a good point, Steve, with the age. That was one of the places where I had to adapt the queries for MIMIC because there are no ages in MIMIC, but there were age ranges in TRACK.
So MIMIC has NICU and adult ICU, but no PICU? Or, okay, yeah, why?
I don't know. That's a good question.
And is it like all adult ICU, like trauma as well as surgical?
I think so.
So the process of making these test collections is very legally complicated. So often they'll sometimes have kind of weird properties, like for example NICU and adult but no PICU, and it could be because there was some legal reason why getting PICU data was harder, or it could be organizational within Bethesda Deaconess where the people that were in charge of the PICU weren't interested in participating, or it could be any number of different things, and it leads to kind of strange, uneven test collections. At least that's my understanding of it. Is that?
I think so.
Yeah.
I don't know if Dina has any. The question, Dina, was why there's no PEDS ICU, but there was neonatal and adult. Do you know about the MIMIC data, why it would omit that?
Yeah, because they send pediatric patients to a different hospital.
Oh, yeah, that would be why.
There we go. Okay.
It's just they don't have PEDS ICU at the hospital.
At the Israel Deaconess. Interesting.
Yeah, probably something like that.
Or children's
They go to
hospital. Children's.
Because the newborn's are already there, so they'll
Yeah.
the newborn ICU because they're there at the mom.
Yeah.
So that's common.
Once you segmented the text, those little fragments of text that are labeled,
Mm-hmm.
those are not allowed to overlap, right?
That's correct.
Do you think, would that help at all if they were? Sorry, it's a total like goofball question.
I don't know if it would help. It might help for the physical exam. I did not break out the different sections of the PE because I didn't want to end up with too many sections. It would have been too much information and I think would have diluted the findings. But it might help in the PE to have like subsections of that.
I just wonder if there's pieces of text that could almost be labeled two directions depending on which part you're looking at. So having overlapping labels.
Not sure I saw anything where
Didn't
that
really
would have
come up.
been. Yeah.
So you're saying like you could, if you want to know if there's ever been, some, like colon cancer being in past medical history and you want to get current, because sometimes it's current, that you could include like chief complaint, history of present illness, and past medical all in one block?
Oh, I'm thinking even finer grain. Like if you have a piece of text, 10 words, and the first 8 words could be labeled one way, and the last 8 words could be labeled a different way. But when in the labeling algorithm, that first 8 words gets captured and labeled, and then it leaves out. So you lose that second label. This is I'm just like.
Although the only labeling, correct me if I'm wrong, the only labeling done here is really the breaking them into sections. So this really is more
Okay.
information retrieval than NLP, where basically Tracy's just segmenting the text into the sections. So there's not any further processing. But that actually is
chunking or something.
Okay, because I thought you were breaking things like allergy and you were labeling a piece of text. I was like, here, this indicates an allergy. That could appear anywhere.
But these were all sections that are typically used when you're documenting a patient's history.
Oh, okay. I see.
The sick part of it is that in most EHRs, these things are actually stored internally as structure, and with this, at least this level of structure, where allergies are in one field, and maybe family, past stuff is in one field, and observed signs are in another field. And when it gets dumped to a repository for something like this kind of analysis, usually that structure gets thrown away, and you have to sort of. So this is sort of implicitly recovering structure, recovering structure that was there implicitly.
I see.
Which is one of the maddening things of working on this kind of data, if you ask me. But
so I have a question about standards. So you had a lot of discharge summaries. Some of the other note types might be more or less able to fit in a standard segment. Did you look at the differences by type, and then did you try and map your segmentation approach to larger standards like CDA, CCDA, something like that?
I did not do that. And what do you mean by looking at them by type?
So, there's a prevalence of the area or the segment in various note types. You sort of look at that, how complete, how good it was across the different note types. How well defined they were, I guess.
I observed differences. I didn't analyze them, but there definitely were differences. And that's why I think if something like this were to happen again, the queries should focus on particular note types because the discharge summaries all had pretty consistent section headings and the types of sections and the type of information documented in each section. The nursing notes weren't as consistent, and so there were things that were documented in a section that you wouldn't necessarily expect it to be.
We talked about, though, adding a table of that kind of thing. These many notes have these sections, breaking it out as far as your write-up goes.
Mm-hmm.
Right? So
Yeah.
it's easy enough to do on this data set.
Yeah, I mean, the other thing that sort of highlights for next step is, if you could automatically sort of write a script that would create these queries to actually add note type as another layer. To do that manually would be really difficult, but you can sort of see, if I look at note title and segment, does that help me in my query? If I test a bunch of different things, do I find approaches that are more likely to lead to better, I mean, you saved your reviewer a lot of work, but you just missed a bunch, right? Your precision and recall weren't as good with the segmented, but the fallout was really good, which, that's good for me. I don't like to do extra work. But for trying to get a big cohort for a clinical trial, that's obviously an issue.
Although if you know you're looking for 100 patients, you could use a segmented query and probably come up with that many and have, it would be much more likely that they'd be relevant and have less work to review them.
Which is why you presented the correlation first, because that's the most sort of positive representation of that concept, essentially, right?
Is there some kind of bias that might be introduced by using segmented as your patient cohort, using the patients retrieved from the segmented versus the... That's one issue. If you were to just use a segmented and have your 100, is there some difference in that patient population?
That could be, like with the colon cancer patients whose colon cancer was documented in the past medical history. If you didn't look there, you might overlook patients who had that condition and had comorbidities.
No, actually, that's an interesting thought that we don't think about much. But because we have this hope that we're going to be able to use narrative patient records to extract all kinds of data and send people for studies. But of course, there's differences in how physicians document, and that could actually introduce bias. Yeah, that's a good point. Probably not addressable in this study, but.
Well, I think the other part of that's crucial is, these are always like a first touch anyhow. Like if you think about the next step for a cohort, you'd actually do a more formal eligibility assessment, for instance, on a set of patients. And if the data is junky, you're going to be asking a lot of patients, a lot of information. Probably your yield on those patients is going to be really low. And so poor documentation probably means this patient's less likely to be eligible for the study. You're going to be wasting your time a lot more. And we know for clinical trialers, there's probably some fatigue that creeps in as people go in if you get too many of them. So I think that's really very relevant. And it's a sort of a very different way. It's the purpose to which you put a tool like this as the primary, thinking about it differently. So that there's really good uses for that, I think.
Okay, well, if there's no further questions from the public, we can excuse the public. Thank you for coming.
That's good, thanks.
Yeah, thanks for coming.
I was not here.
Or yeah. So right.
Well, I know there's a conference room 2 floors on. What is that?
Well, it looks like one of those the whiteboard things.